We're going to talk here about tumors of the bone. And tumors of the bone are primarily a pediatric disorder as far as primary tumors of the bone. And the two most common are Ewing sarcoma and osteogenic sarcoma. Osteogenic sarcoma by far being the number one most common in the pediatric population. With adults, we don't tend to see primary tumors of the bone, and if we do, they're in very, very young adults. The number one tumor of the bone would be metastasis, and then multiple myeloma can also present as a tumor-like lesion of the bone, and then sarcoma of soft tissue is also another thing that's orthopedic in nature, but is not technically a tumor of the bone. So here's some orthopedic tumors as far as what they look like when you're looking at them on X-ray or on MRI. And this isn't my illustration, but this is a really good way to visualize some different ways that you may see lesions on X-ray. So let's start looking at those. So Ewing sarcoma is a primary bone tumor, and this is seen in children. And usually this is going to be in younger children, so elementary school age children, middle school aged, 5 to 15 years of age. It's very, very, very rare to ever see this in patients over the age of 20. Only about 10% of cases occur to patients over the age of 20, and beyond 30, it's pretty much non-existent. This is a rare cancer overall. It only occurs in about 2.9 per million in the US, so that's only about 1 in every 300,000. So this isn't something that you're going to see very often, and a lot of times it's going to be low on your differential diagnosis. This most commonly occurs along the diaphysis, so on the shaft part of the long bones. So places that we're often going to see this are going to be the tibia, the fibula, the femur, the humerus, and so forth. And it's usually right along in the middle. The history in patients with Ewing sarcoma is going to be a low-grade bony pain of insidious onset, but that's really nonspecific. So this is somewhat difficult to diagnose if you're just going off of the history and symptoms alone. What's important is that you note that there's no specific trauma to the affected area, because the first thing we would think if a patient has pain over a bone is that, it's probably a bruise, or they were probably hurt or tripped or fell or something, and that's what's causing the pain. So important in the history that there's no particular trauma over the affected area. The symptoms are going to be consistent with what was mentioned in the history, which would be a persistent low-grade pain over a specific site. And important to document that this is really a low-grade pain. This isn't a really sharp or acute pain. This isn't a severe pain. It's not the kind of thing that we would see in something like osteomyelitis, which would be an acute and very severe pain. This is a persistent, insidious, low-grade pain. It's a dull and aching pain that's been going on for a long time, and a lot of times the patient isn't going to be able to tell you how long it's been going on, because it's been going on for such a long time and it came on so slowly. Occasionally you'll notice a mass, but you can't really rely on that on your physical examination. Most cases of Ewing sarcoma, there's not going to be a palpable mass. And the patient may have general symptoms of metastasis, things like fatigue, weight loss, night sweats, and so forth. For diagnosis, the best initial step is going to be an X-ray of the affected area. There's really no labs that you can do to check for Ewing sarcoma. So really important in any patient that's got this kind of low-grade insidious bone pain that just won't go away is to just get an X-ray. X-rays are cheap, and this is a diagnosis that you want to catch on to sooner rather than later, because once this does metastasize, the prognosis becomes quite poor. It's less than 25% even with therapy. What you're going to see on X-ray, which is consistent with Ewing sarcoma, and which you're responsible for the USMLE to be able to pick out when you see an X-ray on a patient with this kind of consistent history and symptoms is what's known as an onion skinning pattern. And I don't really like that term because it doesn't really look like an onion. So don't think of an onion, really. I mean, remember the term onion skinning, but when you look at it, it's a lot more subtle than just flat out onion skinning. You'll notice some consistent lines in the diaphysis of the bone, but it's quite subtle. So here you can see a line here, a line here. You can even see kind of this line sort of bulging out here along the diaphysis. Notice that little line there? You can barely see it. And then here's another line, another line. I guess it kind of looks like onion skinning in a way. I'm really not a fan of food analogies. It's kind of gross. Okay, so here you can see it again. You see a line here, and the line here, and then a line here. Notice that this bulge here contained, outside of the periosteum, from here up along here, this sort of curvy line, and then the periosteum here of the femur. This enclosed area is called a Codman's triangle, and that's not specific to Ewing sarcoma. You can also see it in osteosarcoma as well, but this is very, very typical, something that you'll see a lot in primary bone tumors. So you can see another Codman's triangle right here, and you can kind of see it right here too. So here's another Ewing sarcoma, and you can see some consistent lines here. So anytime you see this onion skinning, it's going to warrant an immediate referral to an orthopedic surgeon. So here's another one. This one's a little bit less, a little bit more subtle, I suppose. But again, you have Codman's triangle right here. This one, when you first look at it, almost looks like it might be an osteoblastoma. And then here's another rather poorly defined Ewing sarcoma, but you still have these consistent lines, parallel, well, somewhat parallel lines. Okay, so osteogenic sarcoma is another primary bone tumor, and this is the most common primary bone tumor. So whereas with Ewing sarcoma, you only see about 3 cases per million in the US, this is 400 per million. So this is some 120 times more common than the Ewing sarcoma. So you're likely to see this at some point in your career. And this is more commonly seen in older children and even young adults, age 10 through 25. So this is something that you may see in practice even if you're not a pediatrician. This most commonly occurs at the distal femur, and that's something that's quite notable with this particular tumor. Whereas with the Ewing sarcoma, it can really occur anywhere. It just has a predilection for the diaphyses. With the osteogenic sarcoma, it has an anatomic site that it tends to occur at, and that's the distal femur. The history is going to be quite similar to patients with Ewing sarcoma. It's going to be that low-grade pain, insidious onset. A lot of times it's very difficult for the patient to be able to tell you when the pain started because it was so long ago. Sometimes the patient can report a history of trauma. It's not really known what relation this history of trauma has to do with osteogenic sarcoma, but there are a lot of patients who have osteogenic sarcoma who note a trauma in the past, and then the pain from that never really went away. So we really don't know what the trauma has to do with the pain from the osteosarcoma or what the osteosarcoma has to do with the trauma, but don't worry about that. What you do know is that the trauma is not proportional to the duration of the pain. So if I run in and stub my leg against a couch or against a brick wall or something, I may expect to be in pain for a week. But these patients are in pain for 2, 3, 4 months. That's not proportional to the kind of trauma that they endured. And so that's what you're more likely to see even if the patient reports a history of trauma. But more than likely the patient won't report a history of trauma. And that's sort of our findings when we have a bone tumor is that we have bone pain with no history of trauma. The symptoms are going to be, again, pain. Pain is the most common presentation. About 70-80% of patients with osteogenic sarcoma are going to present with pain. As far as diagnosis, it's going to be the same here. The best initial step is going to be X-ray over the affected site. And what we see here is a sunburst pattern. And I don't really know where they get the term sunburst pattern, so really the best way I can describe it, and what I think is a better way to describe it, is more of like a cottony appearance. It looks like cotton when you look on the X-ray. And more importantly, it extends far beyond the periosteal margins most of the time. So it's going to extend outside of the margins of the bone. Whereas with Ewing sarcoma, it usually stays inside the margins of the bone, the margins where we would expect the femur to be or the tibia to be. With osteogenic sarcoma, it expands outside of the bone. So here you see we have our femur here, and then the tumor is actually expanding outside the traditional margins of the femur. Now you can get that with Ewing sarcoma, but usually it's just a little bit that it expands outside. It's just a little bit. With osteogenic sarcoma, it's quite significant. And it's cottony in appearance. It's kind of fluffy looking. Here's another one. I'm not exactly sure what a sunburst is supposed to be, but that's what they tell you. So I think it looks like cotton. You know, those little cotton balls that you use to clean your face with. Okay, so here's another one. This one's not extending too far beyond the margins of the femur, but you can see here that the distal femur is the most common place that this happens. That's where all of these are. Here's another one. This one you might even be able to palpate because it's right up against where the skin is, right here. You feel it right behind the distal thigh. Okay, so now let's talk about adults. Adults, the most common tumor of the bone is metastasis. So how do these patients present? Well, usually these are going to be patients that have some kind of history of a malignant process. So maybe a patient who is in remission or supposedly in remission for cancer, breast cancer, thyroid cancer, colon cancer, prostate cancer. But the presenting symptom is most commonly a pathological fracture. What's a pathological fracture? Well, we don't just see it in metastasis. We see it in other things such as hypocalcemia or you could probably see it in osteoporosis too. But what a pathological fracture is it's a fracture that's just incidental to routine daily activity or insignificant trauma. So if, for instance, I were to bend over to pick up a bag of groceries, or bend over to pick up the newspaper, or my dog were to run into me with his big huge snout of a nose. And I don't know if you've seen my German Shepherd. He's huge, but he definitely should not cause me to break a bone if he just runs into me. Those are pathological fractures. Specifically, just think about a fracture that just should not happen with that kind of trauma. And we would expect a fracture if you fall off of a ladder, or if you fall down a flight of stairs, but you wouldn't expect a fracture if you fall down one step, or if you fall off the couch or something like that. Hopefully that's understandable. So pathological fracture is the most common presentation. For diagnosis, again, here, since pathological fracture is the presenting symptom, you're going to be getting an X-ray anyway. But either way, the best initial step is going to be a diagnosis, or it's going to be an X-ray over the affected area. So and then the therapy is just going to be geared towards the primary tumor. usually the prognosis is going to be pretty poor, because by the time you get metastases to the bone, the cancer is usually pretty disseminated. Now, metastases to the bone come in two different types, blastic and lytic. And usually we see blastic metastases when it's in a prostate cancer, and prostate cancer is the #1 cause of metastasis to the bone. And so usually looking at the hip is a good place to look for metastases of the bone. So you can see, and these aren't lytic lesions here, this is intestine. But one of the great places to look when you're looking for blastic lesions is both the hip, which you can see blastic lesions here and here and here. What you're looking for is just more white. But the best place to look is the vertebrae, and what you see is what's called an ivory vertebrae, and that's this vertebrae here. This vertebrae here, as compared to the vertebrae here, which you barely see. These vertebrae are filled with blastic lesion. Okay, and then here's a lytic lesion. So this we would more commonly see with breast cancer, which is the #1 most common metastasis to the bone in women. And this is a lytic lesion, and that's what we would expect with a lytic lesion. It just looks less like bone. It's eaten out. The bone is just demineralized. So, blastic lesion, which looks like a denser bone, lytic lesion, which is less dense bone. Here you also have lytic lesion. Oh, sorry. No, this is not a lytic lesion. Don't look at that. Okay, that was the picture from the blastic lesion. Sorry about that. Okay. All right, multiple myeloma. So multiple myeloma is another way that you may see a tumor of the bone, but really what this is a tumor of the bone marrow. And I'm not going to belabor multiple myeloma too much, because this is a hematological disorder, and I talk about this ad nauseum in a whole entire section for multiple myeloma. But what I do want to highlight is how it can present as far as the orthopedic disorders. So most commonly, multiple myeloma presents as bone pain, and bone pain is the most common presenting symptom, and it usually is at multiple localized sites. So it's not going to be a generalized bone pain, but what it will be is, oh, I've got this pain in my leg, and I got this pain in my arm, and I got this pain in my head. Just multiple pains of the bone, but in multiple different sites, not generalized. The symptoms for multiple myeloma are mnemonically CRAB, C-R-A-B, and that'd be hypercalcemia on labs, renal failure, which would also show up on labs as disturbed metabolic profile, anemia, and bone pain. So what you're primarily going to see presentation-wise is anemia, which would be, of course, fatigue and bone pain. For diagnosis, you're going to get an X-ray of affected sites. You're going to get routine labs, urinalysis, and a urine protein electrophoresis if we're really thinking multiple myeloma. And anytime you have these CRAB symptoms, you should be thinking multiple myeloma. And so we generally we're thinking more along the lines of just making sure we get our labs, our urinalysis, and then eventually the electrophoresis. But if the patient does have actual bone pain, you should definitely get an X-ray of those sites in addition to your labs and your urinalysis. What will we see with these labs? Well, the X-ray is going to show lytic lesions at the sites of pain. That's what's causing the pain. The labs should show hypercalcemia, which is due to the lytic process in the bones. as well as signs consistent with renal failure, anemia, and then elevated plasma cells. Your urinalysis will show a proteinuria, specifically that's a Bence-Jones protein, and then a urine protein electrophoresis would show a monoclonal spike in the gamma region. And if this is confusing to you, it might be worth a review in the multiple myeloma talk in the hematology section. So this is an example of lytic lesions. So they're just little punched out lesions of the bone. This should be uniform. Here we have these little punched out holes here, and that's just lysis caused from the multiple myeloma. Here's another one, a little bit more pronounced. Here you see just a solitary lytic lesion at the femur. And then here's multiple lytic lesions at the humerus, and you also see what would be a pathologic fracture here. It's a looks like a chalk stick fracture of the middle humerus, transverse fracture. And then here's another one. Here you see a big lytic lesion right here, as well as probably an incomplete transverse fracture. So multiple myeloma, the diagnosis would be confirmed on bone marrow biopsy. The treatment is going to depend on age and comorbidities. Usually healthier patients under the age of 70, we can do bone marrow transplant and chemotherapy. Older patients will usually just do just a chemotherapy to make them more comfortable. Autologous bone marrow therapy is the only cure. So again, for more details on this, you can see the hematology section. I'm not going to belabor this just for this talk. And then sarcoma of the soft tissue. So sarcoma of the soft tissue is, as its name would imply, just sarcoma arising from connective tissue. It's an umbrella term for many distinct types of sarcomas. So rhabdomyosarcoma, which is a sarcoma of the skeletal muscle, leiomyosarcoma, which is a sarcoma of smooth muscle, commonly which we see in the uterus, fibrosarcoma, which is a sarcoma of fibroblasts, and liposarcoma, which is a sarcoma of fat tissue. The soft tissue sarcomas tend to present as an enlarging mass, and they're usually not painful until they get large enough to actually impinge upon a nerve. So this may or may not present as painful. It tends to be painful if it gets bigger because it's more likely to impinge upon a nerve. So it doesn't have to present as painful, but what this is it's an enlarging mass, and it's very, very, very fixed. So it's not going to be something you can move around. It's going to feel like it's attached to something. And this distinguishes it from a lipoma, which is a benign tumor. It's a tumor of fat tissue, and these are more easily movable. If you take the little lipoma in your hand and you feel it in the patient's underneath the patient's skin, it moves around a lot easier than a lipoma, which just feels firm and attached to other tissue in the patient's arm or leg or wherever it is. As far as diagnosis, if you do believe that it is possibly a sarcoma, then the best initial step is going to be an MRI over the mass, which will give you a pretty definitive diagnosis. They usually look pretty obvious. And definitive diagnosis is going to be with a biopsy, and treatment is going to be performed by an orthopedic specialist. So you're not going to be responsible for knowing the treatment beyond MRI for sarcoma of soft tissue, just because of the biopsy and treatment are performed by specialists. They're very rarely performed by actually, I would say they're never performed by primary practitioners or even general surgeons. So just know if you think it's a sarcoma, to get an MRI, and that should be enough for you to do, and it's definitely enough for the USMLE. So they may appear really apparent, like this one, especially if they're over a smaller cavity, so like the toes, for instance. This one's pretty big. I think I picked out a lot of big ones. They're not always big. And then on MRI, you'll see that it's attached to various tissues. So this one's entirely within the muscle, and it even looks like it's got some kind of communication with the bone. This one's in the femur. Alright, and that should be enough. If you have any questions, let me know.